Hello, welcome everyone, and thank you for joining us on Thursday afternoon for a look at the new proportionate approach to our technology appraisal processes. My name is Jen Prescott. I'm a Programme Director at NICE, and I'm responsible for process and operations within our health technology evaluation programmes, and I'll also be chairing the webinar session today. But I'm also joined by four fabulous panelists to help discuss some of the developments within the programme over the last 12 months and what will continue into the coming business year as well. And you'll see on screen we have Eric Lowe, Dahlia Dawood, Ian Watson and Jenna Dilks. This webinar will be recorded, and just a little reminder to please remember to submit any questions or observations you might have via the box on your screen. And we'll put some of your questions to our panel later on for a bit of a Q&A session. Although we might not get round to answering all of them today, I really want to reassure you that we'll go through all of them over time. So please don't be shy about letting us know what you think. And I'm sure I can rely on people out there watching us to certainly tell us your thoughts and your observations. So slides should be coming onto the screen shortly. But in this webinar today, we're going to cover aspects of what is a priority project for NICE, which is the proportionate approach to technology appraisals. We also refer to the project as PAT, or PATT for short, because as everyone that works with NICE knows that we love an acronym. So apologies if we either say proportionate approach or PAT today. It's just a shorter way of trying to describe the project. So we're going to start today's event by taking you through what PAT is, the approaches that we took during the business year, and all of the different pilots that we approached, and what the outcomes were from those pilots and how we'll take those forwards into the next year. But what I first wanted to do was go back and reflect on why we embarked on the whole proportionate approach in the first place. And NICE plays a critical role in the healthcare system in the UK. That's reflected in both legislation and pivotal policies, and namely one of those is the 2019 voluntary scheme, which commits NICE to looking at all new medicines and all significant licence extensions. And at the moment, NICE publishes approximately 100 technology appraisals per year, and if we want to be completely exact, it's 98, but I thought I'd round up just for ease for today. But through our horizon scanning activities, we're expecting that we'll see the need to shift that and increase that to approximately 120 appraisals per year. So that's an uplift of around about 20%, and that's due to many more products going through the regulatory process, becoming licensed and entering onto the UK market as well. So that drives a need for NICE and all of the stakeholders to do more. But we have to recognise that that's already in a pretty constrained environment across many, many different sectors as well. But also not all technologies do easily fit and can easily fit into our existing technology appraisal processes. A few medicines or technologies may take up a large proportion at the moment, whilst that could mean that other potentially simpler appraisals may be delayed due to that investment of time in other areas as well. So we want to try to resolve that. So you could say, or you could describe this as a pretty simple supply and demand problem, but it is one that needs to be resolved to ensure that we as NICE can continue to provide the appropriate level of service that meets the NHS and patients' needs moving forwards. So that has led us to forming the proportionate approach to technology appraisals perspective. So we can clearly see the range and the complexity of medicines that NICE now reviews. It's greater than ever. But not all technologies need the full intensity of the current processes that we have. And some may actually require more. So we should look at that as a scale of potential complexity, and therefore could we be proportionate in our responses to that. So the proportionate approach, or PAT, started with the aim to differentiate our appraisal processes so that some medicines could move through a simpler, a smoother, a faster process, which then would allow us to create more time to consider those complex technologies or those complex appraisals, which may need some more bespoke attention or potentially bespoke processes to develop to evaluate those. But the real aim was to develop a clear route for different types of technologies and different types of value propositions, which will inherently increase our capacity by 20% to get us to that 120 kind of technology appraisal output rate from April 2023. But that needs to ensure that we make the best use of both our internal and external resources, alongside that of our stakeholders that are involved in the process, and that people and patients can access promising treatments as quickly as possible. But whilst considering solving the problem of how to increase NICE's capacity to keep up with the rate of new medicines that are coming through, we can't only consider ourselves. It's not all about NICE, and we have to be, and we are acutely aware of the additional pressure and demand that this would place on our key stakeholders and partners that do contribute to the development of technology appraisal. And without them, the technology appraisals program wouldn't be at the level that it is today. So how can we also help to maximise savings and efficiencies for those key partners and stakeholders, whilst maintaining that requirement to provide access to new medicines through a continued rapid and robust guidance development process as well? And we've outlined the patients in the NHS and life sciences and NICE on this slide, particularly here, but this covers the whole suite of stakeholders that we're trying to service here as well. So I'm going to hand over to the next panelist now, who is Jenna Dilks. And Jenna is an Associate Director within the NICE Technology Appraisal Programme. She's primarily responsible for process and operations. And Jenna's going to talk about the actual approaches that we explored within the proportionate approach over the past year or so. So Jenna, over to you.
Thank you, Jen, and good afternoon, everybody. So as Jen has just been through, we've explained the what is PAT, or the proportional approach, and why it's so important that we undertake this work. But I'm just going to go through a few slides to explain how we undertook the proportional approach work and what those approaches look like. So move on to the next slide. So how did we build the proportionate approach, and what did that undertake? What were those key concepts and principles for us? So we knew, as Jen has already mentioned, that we wanted to expand our capacity by 20% starting from April 23. And that was for ourselves and for NICE stakeholders. And while it was important for us to be efficient and agile in the way in which we do this, we still need to make sure that we maintain that robustness, that transparency, and those world-leading methods and process that we're known for. So we wanted to have some clear principles set out for the proportionate approach work. And that meant that we would include that clinical and economic evaluation, which would enable a value signal and an access recommendation to be made, and that access recommendation would be made using current decision frameworks. So those are clear principles set out for PAT work. But like I said, we wanted to do this in an efficient and agile way. And we agreed we'd do that using test and learn approaches and by piloting the approaches that we identified. So it's not one single solution that will help us to find this 20%. We have to look across multiple avenues and multiple ideas to test them in real pilot appraisals, so appraisals that are ongoing, that we can learn from them as we develop them and adjust as we go, but also involve the key stakeholders, that their feedback would inform the learning and the changes that we make as they're developing. And to do that, we're providing simultaneous benefits so that we can provide guidance and access whilst we're developing these pilots, and therefore building towards the fully fledged methods and processes. So that's the key concept and principles for the proportionate approach work. So that's how we're going to develop it. So we have the what, the why, the how. So we wanted to find those approaches, those multiple avenues that I mentioned, and what are the areas that we needed to look at to find these approaches. And I'm going to go through these 4 key areas with you. So we'll start with front loading. What work can we do in advance? Before the appraisal starts, what can we do up front to save us time, save us resources to find efficiencies? And then we also looked at streamlining. What can we do with the process, the current process, to streamline that? As Jen mentioned, we're doing 100 appraisals a year, but not every one of those appraisals should be run through the standard process. That 9-month single technology appraisal process, it's a quite comprehensive process, and it's not proportionate for us to look at every single one in the same way. As Jen mentioned, some of them may be more complex and may need more time, but some of them could be simplified. They could be done on faster approaches, perhaps. And then we looked at consolidating. So across those 100 appraisals, for example, in a year, some of them will be across the same disease pathway. How can we consolidate those appraisals, and what's a better process for looking at those? And then the final one there is operating efficiently. Now, operating efficiently, you'd say, is part of continuous improvement and should be and is by NICE taken forward every day as part of continuous improvement. But specifically as part of the proportionate approach work, we looked at 3 key areas. And that was improving our operations by aligning similar appraisals. So those similar appraisals that came along, so 2 medicines in the same area, running at the same timelines naturally, how can we build on efficiencies in the process and save ourselves some time and resources whilst maintaining that they are separate appraisals with separate recommendations? And that was the pairs approach. We also looked at optimizing our technical engagement. So technical engagement is a step in the single technology appraisal process, and this step happens before the appraisal committee meeting. The key aim of technical engagement is to identify key issues and resolve them in advance of that first committee meeting. And by doing that, when we get to the first committee meeting, the aim is that the committee can make that recommendation at that first meeting. We found when we looked at the way we were running technical engagement that we were using it for almost 100% of our topics, but we were not realizing the benefits. We were not able to resolve key issues, and we were not getting that first committee outcome. So we were not using technical engagement in a proportionate way at all. So we've looked at the process for how we use technical engagement, how we decide to use it, and we've adapted that and we've improved it so that we can now identify at the key stage, after we've gained the appropriate evidence, critique and submissions, we've identified whether technical engagement will add benefit. And if it does add benefit, we'll use it and we'll add it into the process. And if it doesn't, then it will not be used. And the process for that appraisal will not involve technical engagement. And then the added benefit to that is that that appraisal without technical engagement follows the shortest timeline from start to finish. So it's a quicker process. And then finally there, in operating efficiently, we looked at improving transparency. So this is part of our confidentiality marking. We include academic in confidence information at the moment. So academic in confidence marking, or AIC marking, is used because public disclosure of that information would jeopardize the ability of the data owner to publish that information in a scientific paper. However, in May 2022, the International Committee of Medical Journal Editors identified that publication of that data by a health technology assessment agency or similar was not considered to be a duplicate publication, and therefore NICE do not need to mark that as academic in confidence. Now, this is a change in the process of what we do now with our confidentiality marking, so we have to look into what that means for us and for our stakeholders and implement that appropriately. And we've done that as part of the proportionate approach work. And this, as we've stated, improves transparency, but it also realises efficiencies. So those were the 4 key areas that we looked at: front-loading, streamlining, consolidating and operating efficiently. And we looked across those areas to find the approaches that we use to test, learn and pilot for the proportionate approach. And I'm just going to talk you through one of those first approaches, which was pre-specified assumptions. And this came as part of front-loading. So appraisals often cover ground that's been explored in previous appraisals. However, if we can remove the consideration of issues that have been looked at before, only in low-risk circumstances, and could we then save significant time and resources for not just ourselves, the NICE technical team, but also for the evidence assessment groups that we work with, and for the committee, who no longer have to consider and discuss these issues that have been pre-specified. To do this, we ran a retrospective pilot, and we did this in the summer of 2022. We looked at the 3 most recently published technology appraisals in breast cancer. And we looked to see what pre-specified assumptions we could apply across these 3 appraisals and what time they would have saved if they'd been applied during the course of these appraisals. Now, the outcome from this pilot was that actually, in most areas, there was not sufficient consistency that would allow previous committee preferences to form the basis of a pre-specified assumption. And actually, in the areas that were identified, they were too small to produce any real resource savings. So what we learned, which was great from this test and learn approach, and really sort of showcase that test and learn approach and the way it can work best, is that we'd applied some resource, we'd looked into an approach, and we recognised it wasn't going to be beneficial for ourselves or our stakeholders and other people's resources. So we decided at that point that we wouldn't continue forward with pre-specified assumptions. But there were other benefits as well. Not only had the test and learn approach worked well for us, but also there were other recommendations that came out of the work that was done. So nothing is lost. That work and those recommendations were either going to be taken forward as learning into other PAT approaches, or they would be taken forward as other continuous improvement approaches across NICE. Okay, so I've taken you through just one of the approaches and the pilots that we ran and the outcome of that, but I'm now going to hand over to my colleague, Ian Watson. So Ian is a Senior Technical Advisor for Methods here at NICE, and he was the methods lead for the proportionate approach work. And Ian is going to take us through the other approaches that we looked at, the pilots that we ran, and the outcomes of those pilots. So over to you, Ian.
Thanks very much, Jenna, and good afternoon, everybody. It's great to be here to talk about our work on this proportionate approach. So as Jenna said, I want to talk a little bit more detail about two of the avenues that we explored, two of the strands that we explored, particularly around streamlining and consolidating our work. So I'll just bring up the slides now and start talking about the first sort of area we explored was how we could streamline our approach to cost comparisons. So this is an approach that we use when we're looking at new medicines that are in an existing class or are similar to other medicines that we've previously looked at or previously recommended. Now, we had an established process for this before. Many of you will be familiar with what we term the fast track appraisal process. But what we wanted to do is really build on that and really leverage the benefits and really get the most we could out of our approach to these medicines that are sort of next in class. And we wanted to do that by reconfiguring, simplifying the process that we took. And that's illustrated on the right-hand side of this slide, the process that we've landed on. I think most importantly, really emphasizing the importance of the decision to use this approach, the routing through this approach, moving that early in the process and getting more information and more evidence and more advice to make that decision early on. And then building on that, we can use an abbreviated and shortened and simplified submission and review process to reach a simplified decision making and make a simplified process to make the recommendations. And that can be held by a subset of the committee members outside the need for a formal committee meeting. And I think this is quite exciting for us. It builds on a number of the provisions that we've already had in our processes. But what we found is that we've been able to quite significantly reduce the amount of time that we spend in appraisal for these sorts of medicines, reducing it down to about 23 weeks, so representing a 30 or 45% faster process compared to what we were doing before. And I think this is quite important for us. It's allowing us to get these medicines into the NHS and to patients quickly and efficiently as we can, and it improves the number of treatment options that are available in the NHS. As Jenna described, we took a test and learn approach here, and we piloted this through 3 topics that have already been published, and we learned a huge amount from those. And what that's allowed us to do is, as we were getting to the point that we reach now, we've been able to refine the process that we use and improve the steps that we go through and how we get the information that we need to make sure that it's as robust and future-proof as possible and keep that efficiency in place. So I think it's delivered really quite important benefits, and we're looking forward to rolling that out into the future. As I mentioned, we've already published 3 topics using this pilot approach, and there's more pilots ongoing, as you can see. The next approach we wanted to take was to really look to see how we could expand on that and build on the success of that streamlined approach for cost comparison for similar and medicines already similar to existing medicines, and expand that into a wider group of medicines and and bring that into a wider space to get really more benefit from that streamlining approach. And this, I think, again, is quite exciting for us. It allows us to identify medicines that don't need that full process, the full-blown appraisal process, and we can speed those through and bring them again into the NHS as quickly and sufficiently as possible. And the approach that we're adopting is very much building on the principles of that streamlined approach for cost comparison. So looking early and then taking it through a simplified recommendation process outside the need for a full committee meeting. So the approach that we're adopting is shown here on the left-hand side, following the darker blue boxes. So building on a standard submission and a standard academic review, but based on the information that we find from that, the evidence that's submitted and the review by the academic group, we can reach a decision about whether it's appropriate and whether it's the right and process, whether it's sufficient to take through a streamlined and simplified decision-making process. So that's based on a review of that evidence. So for example, the nature of the evidence, the type of evidence that's available, the clinical need, the clinical environment that we're looking at, the value that medicine may provide, and any gaps in that evidence or uncertainties that might be there. And we can make a full and informed understanding of whether it's appropriate to push this particular medicine, push any particular medicine through a streamlined decision, bring it into the NHS and into final guidance as quickly as possible. As I say, making that final recommendation without the need for a full committee decision, using a subset of the committee in a slightly different format to make that guidance. And as you can see on this slide, that's again reduced the amount of time that we spend in appraisal for these medicines to be reduced down from 44 weeks to 30 weeks, which again I think is an important improvement. And as I mentioned, both of those processes then have been piloted and have produced published guidance. So we've now recommended 5 treatments through these pilot approaches that have sped up our process and improved our capacity. And this is really exciting for us because this has allowed us, as Jenna described, to really test and learn from the appraisal process and get a huge amount of benefit in terms of refining how we approach these appraisals, but at the same time, and more importantly, to make live recommendations to the NHS and secure the rapid access to these medicines for patients, and to do that efficiently. And I think that's great news for NICE, and I think it's great news for the NHS. So what were they? Well, the first one was a medicine called somatrogon for treating growth disturbance, which we sped up by around 7 weeks. And we then built on that and improved on that as we went through other pilots. So the second one was nintedanib for treating idiopathic pulmonary fibrosis. Then into February, the second cost comparison was a medicine called vutrisiran for treating a form of amyloidosis, a very rare condition. And that one, we were able to recommend that 20 weeks quicker than we otherwise would have been able to, which I think is great news for patients with that condition. And then into March, 2 more recommendations. The first, eptinezumab for migraine, followed by nivolumab for lung cancer, which is a piece of draft guidance, draft recommendation. Again, speeding up by 8 or 9 weeks, the recommendations. So that summarizes our streamlined approach, the streamlining aspect. The next component I wanted to talk about falls under the heading of consolidating. And this is a really exciting area for us, and quite an ambitious approach, and quite a substantial departure from the approaches that we've adopted in the past or been using over the recent years. And as such, it's quite a large project. It's quite ambitious and quite large. So we'll take longer to complete than the streamlined approaches. Nevertheless, it's moving really quite quickly now, and we're starting to gather some momentum. But the concept here is that we can think about how we can consolidate and improve efficiency for appraisals within a disease pathway, while at the same time producing better guidance and improving how we present that guidance and information to the NHS, to doctors, and to patients. And when we look back across our past appraisals, we've seen that more than 40%, so almost half of our appraisals, arise in only 10 disease areas. So there's a huge amount of commonality in those, which allows us the opportunity to consolidate across a single disease pathway and capture several different appraisals, several different medicines at different points in the pathway, and consolidate that into a single ongoing appraisal. So we propose to do an ongoing appraisal that spans several medicines across that whole disease pathway. And that's built on the principle of first building an economic model upfront through an academic partner, and then using that model alongside the evidence that's submitted to us by companies and by patients and by clinicians and by other stakeholders to build that into making recommendations. And we are building an approach that allows recommendations to be made for individual medicines at the right time across the disease pathway. And it also allows us opportunities to stretch what we're able to do. So thinking about different types of guidance, a more dynamic reflection of the pathway, and make innovative use of evidence, and in particular real world data. I think there's a really great opportunity for us to really use the power of real world data and the power of the data sources that we have available to really fully understand and properly characterize the disease pathway and make relevant recommendations for the NHS, while at the same time we come back to the opportunity to really quite significantly generate economies of scale, both for NICE and for those who are submitting to us. So there's no need for us to each time have a whole new model built and the whole critique again. We have a common model that allows us to really understand that disease pathway and make those recommendations. So how are we approaching this? Again, using pilots, and in this case, there's 2 disease area pilots that we're using, shown on the bottom right. So the first is in kidney cancer, or renal cell carcinoma, and that one's moving most quickly. That one started the first, so we've been through a scoping process for that, and now we're really ramping up speed into the development of the recommendations, into the development of the guidance process, and into the appraisal. So that's really ramping up over the course of this year and into the later parts of this year, and followed swiftly on its heels by lung cancer pathway. So that one's at a slightly earlier stage. So that the scoping process for that is now firmly underway this month and next, with a view to ramping up again later in this year. And I think this approach, as I said, is very exciting. It's quite a major departure from our previous approaches, and gives us quite a lot of opportunity to really stretch and improve on how we're working in a proportionate way. And with that, then I can hand over to Dalia, who will be speaking next. So Dalia is Associate Director for Research in our Science Policy and Research team, and is going to be talking a little bit about how we're approaching managed access. So thank you very much, and over to you, Dalia.
Thanks, Ian, and thanks everyone for joining us today. So I will now briefly summarize our ongoing work to improve the timeliness of the process of entry to managed access for the drugs that will require managed access agreements. So this work was undertaken to achieve 2 main objectives, actually. Firstly, we wanted to speed up the patient access to medicines so that it can begin at the time of marketing authorization or very shortly after for all MHRA regulatory routes. We wanted also to explore whether a more efficient and less resource-intensive process is appropriate for topics that are highly likely to require managed access. because essentially at the moment we have two STAs, or two single technology appraisals, one at the entry point and one at the exit after the managed entry agreement period. This work is led by the newly established NICE HTA Innovation Laboratory, or HTA Lab function, using a collaborative and iterative multi-stakeholder approach in order to achieve the above objectives. So what we have done to date and what we concluded from these intensive engagements, as well as reviewing our past appraisals, is that NICE Managed Access team, together with our colleagues at NHS England, can accurately actually identify the drugs that are highly likely to require managed access very early in the appraisal process. However, this making changes around that will mean that we might need to change the managed access policy and processes, which has to be delivered actually in partnership with NHS England. And without any change in policy at the moment, a redesigned NICE process and must deliver the same information to support NHS England commercial negotiations. Nevertheless, in the meantime, we can improve the timeliness and streamline the decision-making process in the same way that has been applied to other pilots that Ian just briefly summarized. So streamlining the decision-making step of the appraisal is where we are able to make some efficiencies and speed up the process at the moment. So at the moment, our next step in the shorter term is to start piloting the streamlined decision-making step of the appraisal process on a medicine to be identified as highly likely to require managed access, while we try to develop more radical approaches to deliver efficient and fully aligned regulatory and patient access pathways to important new medicines. For example, possible approaches that could be alternative to how we are conducting our economic evaluations now to specify the plausible ISA range, simpler and quicker submission processes and critique of the submission. So our next step is really to explore this through further research and try to develop this approach to achieve the objectives of speeding up the entry to managed access through exploring the value of using alternative methods, for example, the use of early economic models and other possible alternative approaches. And with that, I'm handing over, to Eric to present the patient perspective. So over to you, Eric.
Thank you very much. And it's a pleasure to be taking part in the webinar. So just before my slides come up, I'll just start with an intended pun, in so much as that I think NICE deserve a huge pat on the back for this initiative. I think it's very sensible, it's pragmatic, it's practical, and I think it strikes a balance between that pragmatism and practicality, but there's a sufficient level of methodology and process in place. And I think when so much of what NICE does and so much of HTA is beyond the understanding of averagely smart lay people like me, when it's sort of about health economics and statistics, this is an initiative that I think will resonate very well with patient organizations and communities, because they'll understand it and they'll see the benefit to them in doing this. And I think that's important, because I think for patients and patient organizations taking part in a NICE appraisal, it's not for the lighthearted. It's not for the lighthearted. I took part in my first one in 2000, and then probably averaged one every year for the next 15 years. And I have the scars to prove it, probably physically and emotionally. And we keep hearing about sort of opportunity cost in an economics sense, but there's a huge opportunity cost for patient organizations taking part in a NICE appraisal, because it's very, very intensive if they're fully embedded in the process. And as a consequence of doing that, they're not doing other things that could be more valuable and more important to their patients. And that's why I think taking a proportionate and agile approach to some appraisals will be really helpful and really sensible for patient organizations and patients. Importantly, because it just strikes a balance between the pragmatism, but having the trust in the methods that NICE will still make the right decision about treatments that are approved for use on the NHS. So there are other things to like about the process as well, or the initiative, is I really like the agility. I think Jen mentioned that earlier on. It's complex. Things don't come to NICE necessarily in a nice packaged way with a bow on it, and therefore you have to have a range of options to try and solve the problem. I think the fact that the process is front-loaded is really important, and I'll talk a little bit about that on my next slide. That I think the more work that can be done before NICE, it takes the pressure off the appraisal process. I think it takes the pressure off the need for huge discounts and managed access. So I think that's really, really important. I think Ian talked a little bit about the consolidation. So one of the challenges that NICE have is in ensuring their guidance delivers what I would call a state-of-the-art clinical pathway as opposed to a consequential clinical pathway, because it's a very piecemeal approach, because they just have to look at the data, it comes randomly, and they have to shoehorn that into a pathway. And by taking a pathway approach, I think it helps NICE to work with clinicians, to work with NHS England, and try and make more meaningful clinical pathways for patients and clinicians. So there's lots of things to like about this. And I think the fact that they're taking a sort of test and pilot approach, I think is really important, because I don't want to single out acronyms that have come before, but a lot of acronyms have come before that haven't been thought through properly, and actually you could argue have been more harmful than helpful. So the fact that NICE are taking a stepwise approach here, I think is very sensible and very reassuring. But it's complex and difficult, and I think this approach won't please everybody. And I know there's probably some thoroughbred health economists out there that are thinking, oh, what's all this about? So I think it's important that there are some guardrails in place. And from my experience, at least, there's no two appraisals are the same, even in the same therapeutic area. And there's always skeletons and things lurking in the corners of a data set that are problematic, even in the same therapeutic area. So I think that's why it's really important that NICE still maintain a robustness of that interrogation of the data, and not let things slip through that could be harmful to patients and would constitute a poor use of scarce healthcare resources. And we talk about low risk, but I'm not sure anything's low risk. It's just less risk than something that's really, really high risk. There's risks everywhere because there's a lot of uncertainty in data sets that come to NICE. And I think it's important that we guard against thinking all of this is risk-free. There will always be risks because of the nature of uncertainty in data. I think also we need to be cautious of this signaling to industry. I mean, one of my concerns over many, many years, particularly with managed access, is it doesn't really matter what type of data that NICE get given. It could be good, it could be bad, it could be mediocre, it could be rubbish, but we'll find a way to get it over the line, whether it's through patient access schemes or managed access. And all these things have their role, but need to be used thoughtfully, and in my opinion should be the exception, not the rule, because I don't think it signals enough to industry and to academia that actually the opportunity to improve access is before things get to NICE, which is improving evidence development, and particularly de-risking regulatory data sets from a UK perspective. It's like any system, rubbish in, rubbish out. And so NICE and NHS England can do great things with initiatives such as PAT, but fundamentally, I think what patients need and what patients want is better evidence development and better inputs into the system, because that's when the system will start to work better. And with that in mind, I sort of, with some help from my colleague, I sort of put together this slide that for me proposes a concept that we should think about managed access differently and more holistically, because managed access is here to stay. We're going to see more of it, but it needs to be thought about in the right way. And we need to look about where managed access starts and kind of where it finishes. And in my opinion, it shouldn't just start at the point where NICE have a data set and discover that there are issues. So on the left-hand side is a sort of model of how I see the world, or have seen the world for the past 20 years, where NICE are struggling with a regulatory data set. So the data that NICE deal with are data that come from regulatory studies that are designed for the most part to answer regulatory questions. They're not designed to answer the questions that clinicians in England, patients in England, and decision makers in England are necessarily interested in. That means there's a ton of uncertainty when a data set gets to NICE. And that's why partly the front loading thing in the PAC process is really important. As a consequence of that, we get ACD documents with hundreds of pages explaining the uncertainties and what the issues are. Companies, unfortunately, have to fork out huge discounts to buy off that uncertainty, or have the prospect of managed access, which isn't always in the best interest of kind of patients. As we've talked about before, this leads to optimized guidance sometimes, and a consequential pathway, not a state-of-the-art pathway. As a consequence of that, the NHS buys a large proportion of costs, not outcomes, and I think it gives a poor signal to industry. Whereas on the right-hand side, it proposes this new concept where we leverage the incredible research capability of the NHS in England, the huge investment that's already gone into clinical research, but actually doesn't help solve NICE's problem of uncertainty, because the research that's done through clinical trials and academia is not linked to that decision-making framework. So this proposes an alignment between commercial and academic research through hybrid studies, where we partner with industry to de-risk that data set by leveraging the clinical trial capabilities that we have in the UK to produce a more holistic, more generalizable, more appropriate data set that would go into the health economic model and the kind of NICE submission. And I think we need to think about that as a concept of market, of managed access, but just a little bit before NICE, because it's all loaded towards after NICE. And I think I reflect on the CDF budget and the IMF budget, and I'd be lying if I said I was a massive fan of either. They have their role, but it's an enormous amount of money. And I can't help think if 50% of that was put into a research fund, specifically aimed at working collaboratively with academic groups and industry to de-risk their regulatory data sets, it's much more valuable, much more sensible, and a far better use of scarce resources and taxpayer. And then there will still be some stuff left in these funds for addressing the uncertainty that couldn't have been addressed previously through appropriate research development. So I think for me, Pat gives us this springboard into having this discussion now. It's headed in the right direction, but the more we can do to front load NICE appraisals, and the more we can collaborate and help generate the evidence, the more the NICE process, appraisal process will work, and the more relevant and clinically plausible NICE guidance will be for patients and clinicians on the NHS. So with that, I will stop and pass back to Jenna, but just to say thank you, NICE, for doing something for you. Rather than have things done to you, you've done something really pragmatic and sensible for you, from which I'm sure patients will benefit.
Thanks, Eric, and some really thought-provoking words from you there as well. And thank you very much as well for that virtual pat on the back. That was very kind of you. So just to finish up on a couple of the slides, we just wanted to highlight to you what is going to be happening next with the proportionate approach to technology appraisals. Just before the slides come back on screen, I'll keep going as the slides do come back. So PAT isn't going to be stopping as of March. Nice working business years, so 1st of April to the 31st of March each year. And I wouldn't want anybody to kind of come away from this webinar thinking that as of the 31st of March 2023, the proportionate approach will be over. It needs to continue. We shouldn't stop. We don't want to stop, and we need to maintain that ambition and that strive to continue to improve the processes, continue to make them as efficient as possible, and continue to strive to get access for patients in as rapid a way, but as robust a way as possible. So that's where we're talking about the ongoing pilots in the pathways approach, and Dahlia talked about the rapid entry to managed access and what would happen this year. And we also have other ideas of other creative and potentially innovative process areas we think we could start to do some development work on as well through the 2023-2024 business year as well. So please watch this space for that. But ultimately, what we want to do at this point is convert and translate the success of the streamlined pilots into formalized processes next year, so that we can start to gain the benefit and use them on more and more technologies that are coming through. So our plan is to publish interim methods and processes in April 2023. So that's only next month, so it won't be too far away. And then what will happen moving through time is, as we continue to embed and establish these processes, we will be seeking to formally put them into the manual for the Centre for Health Technology Evaluation Processes via a formal modular update as well. So that will be happening through the next year also. But this will always be now about how do we go through a system of quality and process improvements as well moving forwards. But Pat is here to stay in a way, but that's a good thing, I think, and I think that provides a benefit for everybody. So whilst we take the slides down, I think there is a little bit of time for some Q&A. And there are quite a few questions that have come through already, which is fantastic. And thank you all for bearing with us. We've had a lot to tell you about. It's really exciting how we're getting to this kind of endpoint of the first phase of the proportionate approach. So I'm just going to take a look at some of the questions and ask some of the panelists to respond. So Jenna, there's a question about kind of the distribution of types of topics on the work programme. And someone's asked about is the majority of TA guidance at the moment for cancer drugs? Is that correct? And will there be an increase in cancer drug output over the next few years with the proportionate approach?
Okay, thanks, Jen. So the short answer is the increase that we're expecting, so from that 100 to 120, is across the board. But sort of to answer your question more specifically, the proportion of cancer drugs versus non-cancer in the appraisals programme is actually at 51%. So that's 51% cancer drugs in 21-22 compared to 49% for non-cancer. So really is split down the middle. And that's for 21-22 because we're not quite at the end of 2022-23 yet. So we've not quite finished the calculations for that year. And also just to highlight as well that for those 51% of cancer drugs that we looked at in 21-22, we did have a 92% positive recommendation rate for those as well. So as Jen mentioned right at the very beginning of the presentation, if you can think back to then, we've seen quite a few slides and a few people since then, but NICE in the 2019 VS, we were asked to look at all new medicines and indications. So that's across the board. It's not just predominantly fixated on cancer drugs. So the increase that we're expecting is not just cancer drugs, but it does include cancer drugs. So yeah, the short answer is you can expect an increase in cancer drugs as well, but it is across the board and in all disease areas.
Brilliant, thanks, Jenna. Dahlia, a question for you, if that's okay. So there's a watcher who's linked together one of the other NICE priorities, which is the early value assessment going on, and they've asked how the proportionate approach and the early value assessment perhaps overlap or complement each other.
Yeah, so the early value assessment.
Finish the question for you, shouldn't I? We're able to explain what that might look like.
Yeah. So yearly value assessment, or as we call it, EVA, is primarily for medtech, for digital health and devices and diagnostics, or digital products, devices and diagnostics specifically, while the PAT approach is now developed for medicines specifically. They both are trying to improve or the timeliness of access to these technologies. They develop differently, but ultimately both need to work together actually to ensure that there is no unwarranted variance in the processes and the stakeholders' experience moving forward. And this is a key point on our agenda for the next stage of work on PAT and EVA as well.
Okay, fantastic. Thanks, Dahlia. Ian, if I could come to you next. We've referred it throughout the whole kind of presentation and talk about PAT, about this scale of, we have complex appraisals coming our way that might need more time, more attention from the process, to the low risk appraisals that we think we can apply a much more streamlined approach to. Have you got examples that you could give of either side of that scale?
Yes, absolutely. Well, there's no sort of single definition of complexity or risk, high or low risk. And I think Eric put it really, really helpfully then as well to describe how low risk really means lower risk. But there's no sort of single scale. It's any aspect of the evaluation or the appraisal that can indicate that more or less scrutiny or investigation or consideration is needed, and that means that we have actually embarked on a piece of work as part of this project to understand all the different sort of facets of risks and complexities that arise in appraisal. It's not something we're able to go into in a lot of detail today just because of time, but it's been a quite helpful process just to understand all of the different facets. So some of those, for example, would be the evidence in the particular appraisal. So what's the nature of the evidence, the complexity of the evidence, the amount of certainty or otherwise in the evidence. But other aspects might be the value proposition, the economics, or the complexity of the clinical scenario. Perhaps it's a more or less complex clinical pathway or commissioning environment in the health service, any of those different aspects. And of course, the impact on the patients would be an absolutely critical consideration when you're thinking about the extent of risk that is being considered within an evaluation, the nature of the condition for people who are affected, the nature of the treatments that are available, the nature of the new technology that's being considered. So that's a really sort of a central consideration in that. So it's not a single answer. There's all sorts of answers in it. I'm sure we can discuss that a lot more when we write more about the proportionate approaches. But yeah, it's a full picture of all of the different aspects of the appraisal that can influence that discussion of complexity or risk.
Thanks, Ian. Jenna, if I could come back to you, there's a few questions that are kind of that are related, and it's more about how products are selected for the proportionate approach. And there's a question almost related as, how does this differ from what was the fast track appraisal or the FTA that we originally had a few years ago?
Yeah. Okay. Thanks, Jen. So how technology is selected for proportionate approach, and how is that different from fast track appraisal? So it depends which proportionate approach we're looking at. So they do differ slightly. And so we'll focus first on the cost comparison. So cost comparison approach is now looking, it's what fast track appraisal used to be. But anybody who was involved in the fast track appraisals that we had before, they'll know that they took the same length of time as a standard appraisal, a single technology appraisal, and they were just exactly the same length. But the cost comparison, as we identified in the slide, is cutting down the time almost by half in the appraisal process. Now, we can identify the technologies that we believe we will route through the cost comparison process at the scoping stage. So this is ahead of the appraisal starting, when we gather in evidence at that scoping consultation and the workshop. We can consider that evidence and NICE will select that process for cost comparison. So we can identify those early on. However, when we come to the streamlined, the expansion of the streamlined process, so when we're looking at the other medicines, not cost comparison, that will come later on in the process. So to be able to make that decision, to find out which topics are appropriate, we need to be able to see the submissions that come through from all the stakeholders and also the evidence critique from our external assessment group. So around about 18 to 20, I think it's about 18 weeks into the process, once we've gathered submissions and we've done that evidence critique, we can then look at all that evidence and that critique and the submissions and then take a decision on whether a topic is appropriate for entry into the streamlined decision-making process. So it's different, and it really does depend on the process that you're looking at. Now, that was just streamlined. When it comes to pathways, and that's an ongoing pilot, as Ian mentioned, so there's still more work to do on pathway process before it's defined and it's put into any sort of business as usual, and that's ongoing through the next year. But pathways, as well, again, like cost comparison, is identified in advance. So we'll identify that before scoping. We'll identify whether topics are suitable for that pathway, and we'll scope them together as part of a scoping pathway.
Great, thanks, Jenna. Fabulous. And I assume a lot of that would go into the interim process and method statement as well, wouldn't it, to really be clear and show that predictability of that decision-making process as well. Okay.
Yeah, absolutely.
Fantastic.
And people will look out from that in early April.
Wonderful. Eric, I'm not going to let you get away with it. You've got to get a question. Just on the thoughts of how NICE have talked about, we'll be making this easier for patients and the NHS to get involved in technology appraisals for where we've applied proportionate approaches. Can you explain from your perspective how you think this might kind of carry through, I guess, as someone looking in on Pat, and as you said, experience of previous appraisals that you still bear the scars of? What's your perspective on that?
So I think it's the kind of proportionality, and I think it's around, I think the more that there can be heavy lifting done up front, the better, because I think that gives the kind of a better entry point into the system, because a lot of the jeopardy and the stress comes from the risk of a no decision from NICE. It's very challenging for patient organizations to be in that situation, because they carry the weight of their community on their shoulders to get a yes out of the system. And despite the fact that NICE, I think, lead the global sort of HTA world on patient involvement, it's still not clear really what actual benefit the patient voice has in the process, because it's so dominated by the economic model and the evidence. So by front loading it, and I think the key thing for the patient voice is it needs to be in the core data set. It needs to be captured in the trial endpoints. It needs to be captured in the health economic model for it to have the biggest impact on the decision making. If it's not in the model and it's not in the evidence submission, it's useful to have that patient voice, but it doesn't really impact on the decision massively. So by front loading things through a more proportionate approach, and I think in giving patient organizations to get involved earlier, is much, much better than having them rock up to a committee meeting with the pressure on them to perform in what is often quite a hostile environment.
Thanks, Eric. Now we have 1 minute till 3, so I don't think we've got time for any other questions. But with that, I just wanted to say thank you to our 4 panelists. You've been amazing. Thank you so much for answering the questions that have come through on the Q&A session as well. But also thank you to everybody out there that's come through and watched the webinar on the PAT process, and everybody that got involved in the pilots. It has been a really fantastic experience, and everybody's really connected with the test and learn and really wanted to help us kind of get a positive experience in this area. So I just wanted to say thank you to all of you out there that are also involved in it a little bit more. So with that, thank you so much. Hope you've enjoyed the webinar, and I hope you continue to watch and observe how PAT develops over the next month and years. Thank you so much, everyone. Bye.